Hi everyone, welcome to episode 4 of a comprehensive review of dermatopathology. Today we're going to be covering all things vasculopathic, which is kind of a broad term for any process that involves a vessel. So this could be perivascular infiltrates where the inflammation comes in through the vessels, to damaging the vessels, to clotting the vessels. So in this chapter we're going to talk about non-inflammatory purpuras, vaso-occlusive diseases, and then other things that are just kind of put in the vasculopathic category, for lack of a better place. So urticarias and, things like these lymphocytic vasculitides, in addition to true vasculitis. We're going to cover sort of all of them. So we'll start with vaso-occlusive. So these conditions are what we consider vasculopathic, in that there are thrombi or collections of calcium in vessels. And then there's secondary inflammation as a result of that. Usually this inflammation is kind of not so much a primary looking inflammation, but a reactive inflammation. So there's more clot relative to inflammation. And things that fall into this category are cryoglobulinemia, cholesterol emboli, antiphospholipid syndrome, Coumadin necrosis, DIC, factor V Leiden. So as an example, here's a case of cryoglobulinemia, and you see inside of these vessel spaces, you can tell it's a blood vessels because you see these endothelial cells lining this space. They're filled with this gummy pink material that's not red blood cells, which you could see in contrast to it right there. And so this fibrin in the vessels indicates that they've been plugged, and you do have a few inflammatory cells around it, but not so much anything that looks like a primary inflammation. Here's an example of a case of factor V Leiden, and now your clotting has caused necrosis of the epidermis and a section of the dermis, which makes sense. You have loss of perfusion. And when you go in, what you can see is this gummy pink material, the fibrin inside of the blood vessels here, necrosing off the blood vessels and thereby necrosing the tissue. You see a few lymphocytes, maybe a few histiocytes, but not a significant amount of inflammation relative to how much clot you see. Here's another area where you can see the fibrin in the vessels and the damage to the tissue. Here's a case of calciphylaxis. So similarly, you have another area. This is an eschar, where you have necrotic tissue and inflammatory cells all kind of collected together. And then deep to that, you're going to see something likely vaso-occlusive. And so here's a closer picture of the eschar. And then here is a little bit of calcium in a vessel, and here's a larger bit of calcium in a vessel. And this amount of loss of perfusion that happens acutely could certainly necrose off the tissue. So those are examples of vaso-occlusive things. In contrast, when we talk about vasculitis, we are talking about a primary inflammatory process that then damages the endothelial cells, causing the fibrin deposition. And so in this case, we usually see more inflammation relative to the amount of clot. And so these are going to be things like leukocytoclastic vasculitis, Henoch-Schönlein purpura, septic vasculitis, and then some of these other entities like EED and granuloma faciale, where we may see a vasculitis in the sections, or our systemic vasculitides, like our ANCA vasculitides and PAN. So for LCV and Henoch-Schönlein purpura, the findings would be about the same. And for the most part, you could categorize this as an allergic reaction, either to an infection or to a drug that then causes damage to the vessels. You're going to see neutrophils, plus or minus eosinophils, but you usually do see eosinophils. And then you see neutrophilic karyarexis. So karyarexis is the name for nuclear dust, right? And when it's from a neutrophil, it's more specifically called leukocytoplasis. And then endothelial damage, when you see it, is going to look like swollen endothelial cells. And if you see fibrin, that's an indication that there's been damage. So here is a routine LCV. And what you can see is in the dermis, you see extravasated erythrocytes. That's hemorrhage. And that could be biopsy related. It could be, a bruise, but it could also be due to inflammation or damage to the vessels. And so we see a fair amount of inflammation here. And when we zoom in, you're going to see that around this vessel, You have lymphocytes, you have histiocytes, but you also have neutrophils. So we'll see our multi-lobe nuclei. And we also have eosinophils, where you can see the glistening red granules of the inflammatory cells. And then you also have all of these little random particles that are too small to be lymphocytes and too big to be nothing. Those are the karyorrhexis of the neutrophils, the leukocytoclasis. And you can see here that this inflammation is damaging this vessel because you have these pink globs inside the vessel, indicating a clot secondary to this inflammatory process here. Here's another section where you can see this vessel, and these endothelial cells are kind of not very happy. You have neutrophils all around. You should have eosinophils present, and then you see these little fibrin clots. So lots of primary inflammation and a little bit of clotting and some extravasated erythrocytes. Those are the findings that you see in leukocytoclastic vasculitis, and it of course affects your superficial, your small capillary vessels. Here's an example of a vasculitis where you have lost viability, again, of your epidermis and the superficial part of your dermis. And when you look, you have lots of inflammation, and you see this kind of hazy pink stuff. That's the fibrin, indicating vessel damage. And then you have a lot of these inflammatory cells with a lot of dust here. Now you can see more easily all of this nuclear dust. And this is a case, I believe, of Henoch-Schönlein purpura. So neutrophilic dust, damage to your vessels. Sometimes you can't even see the outline of your vessel anymore. All you see is the shadow of it with the fibrin. Oh, sorry, that was just LCV. Here's the Henoch-Schönlein purpura case, where you've got enough vessel damage that you've lost viability of your tissue above, but when you go in, here you see your newts and your eos and your fibrin in your vessels, indicating damage to the vessels. So it's not just a perivascular infiltrate. You can even have perivascular inflammation with purpura, which you see in drug, but not vasculitis, which you require seeing fibrin and damage to the vessels to make that diagnosis. Okay, up closer, here's the color of red blood cells. Here's this kind of pink hazy fibrin that you can see in the vessels. So in contrast, here's a vasculopathy versus a vasculitis, and you can see this primary inflammation, these eos and these newts, as opposed to just, a few inflammatory cells as cleanup. Septic vasculitis is vasculitis that also has thrombi, and if you're lucky, you can see some neutrophils in and around the vessels and possibly even some organisms. So septic vasculitis, we might see our meningococcemia or gonococcemia. Here's an example where you've lost viability. You have an eschar and an ulcer, and you look up close and you see, going back, you see this superficial and deep infiltrate. It's quite dense with inflammation. And then if we hone in over here, we can see a vessel where we have neutrophils, not so many eosinophils, because this is not so much an allergic reaction in this case. And you see inside a vessel, you have a thrombus and you have neutrophils, and you might even see bacterial cocci if you're lucky. So that was a case of gonococcemia, which clinically shows up as these little necrotic papules. So that eschar you saw on top correlates with that necrotic papule that you see. Granuloma faciale is in this chapter because you have a dense infiltrate, and sometimes you can see changes of vasculitis in your infiltrate. This is one of these diagnoses where I say everybody's at the party. That's how I learned it. That means all of the inflammatory cells are there. You'll see neutrophils, eosinophils, lymphocytes, histiocytes, and plasma cells. And everybody learns about this Gren zone, but it's important to keep in mind that a Gren zone simply means that you have a dense infiltrate in the dermis. And so you'll see a space between that infiltrate and the epidermis. It doesn't slam up against it. It doesn't sort of obscure it. It is in the dermis. That's all that's significant. So there's a dense dermal infiltrate. and you may or may not see vasculitis. So here is your dense dermal infiltrate, and as you can see, there's a little space between it and the epidermis. And if that's helpful for you, great. If not, it's not like a major finding. But here up close, you can see that you have a mixture of inflammatory cells. You have lymphocytes, which are the dark black nuclei with no cytoplasm. You have histiocytes, which are these kind of more purplish oval shaped cells. You have neutrophils, which are your multinucleated dotty cells. You have eosinophils, which are your red ones with these glistening granules. And you have plasma cells, which have an eccentric nucleus and this little stippled or clock-faced nucleus. It's like little dots of dark chromatin on a lighter nucleus. Here's another shot. So this is easier to see, the plasma cells. You see this nucleus is off center. That's what they mean, eccentric nucleus. They don't mean the personality is eccentric. And then here you see how the little face of the nucleus is speckly. That's what a plasma cell looks like. Here's your eosinophils with your nice granules. Here's your neutrophils. Remember, they also have a fairly red cytoplasm, but it's just not as red as an eosinophil and doesn't have the granules in it. And then you have lymphocytes and plasma cells and histiocytes. All right, so Erythema elevatum diutinum, actually early lesions can look just like granuloma faciale. They probably have more newts than eos, and granuloma faciale tends to have prominent eos, but early on it can look identical, or you could have this more perivascular infiltrative neutrophils. And regardless, you can see vessel damage, i.e. vasculitis, but you don't necessarily. And then when we think of erythema elevatum diutinum, we're usually thinking of late lesions where you've developed a fair amount of fibrosis, and that's when you start to see the nodule that we associate with the clinical images in our textbooks. So here's a kind of middle-aged version of erythema elevatum diutinum. You're starting to see the fibrosis, which is showing up as this white space between the collagen bundles. And then you can see a fairly dense neutrophilic infiltrate. So you have the little dots that are the nuclei that are going around the vessels, and you may or may not see a little bit of vessel damage. Here's a closer look of your neutrophils going around your blood vessels. And then here's an older lesion, a more well-developed lesion. This one is going to appear as a nodule because now you have what I consider this kind of sclerotic fibroma pattern, that wood grain fibrotic pattern that we see with sclerotic fibromas, except this one is quite cellular in that there's this neutrophilic infiltrate. So if you see a nodular fibrotic pattern that sort of reminds you of a sclerotic fibroma, but it's studded with these neutrophils, then you think about a late stage of erythema elevatum diutinum. Okay, moving on to systemic vasculitides. So these are our ANCA-associated vasculitides, which have been renamed, but it's hard for names to change in dermatology. So granulomatosis with polyangiitis would be what we used to call Wegener's, and microscopic polyangiitis. And then, of course, there's polyarteritis nodosa. So I don't have a great picture of these, but basically you have a deeper vasculitis or a superficial and deep vasculitis, plus or minus a bunch of granulomatous features. Polyarteritis nodosa is the artery that gets inflamed at the bifurcation site at the junction of the dermis and the fat. And these are distinguished from leukocytoclastic vasculitis, which is the small vessels on the top of the dermis, like we saw earlier. So vasculitis with granulomatosis. Allergic granulomatosis used to be called Church-Strauss. Granulomatosis with polyangiitis used to be called Wegener's. Here's a picture I pulled from Wikipedia, and you can see that you have vasculitis around these kind of larger vessels, and then you have this fairly intense granulomatous infiltrate surrounding it. Polyarteritis nodosa tends to be a very kind of compact vasculitis that occurs right around the vessel. And it's specifically around arterioles, so not veins, but arteries. And it usually occurs at the bifurcation site, which is the size of the vessel that we see right at the top of the fat near the dermis. So here right in our subcutaneous tissue, we see a muscular walled artery surrounded by inflammation. Some of the inflammation spills into the fat, but for the most part, it's localized around the vessel, which we'll see in contrast to things in the panniculitis chapter where you have panniculitis and inflammation of all the fat, plus you might see vascular changes. So that'll be an important distinction. But here you can see this muscular wall of the artery. And then you can see a lot of inflammation. It'll be mixed neutrophils, you might see eosinophils, that early type of vasculitis inflammation. And then you can see mixed in here that hazy pink color of the fibrin, indicating that the vessel wall is being damaged and this inflammation is not simply coming out of the vessel. Here's another case of polyarteritis nodosum, and you can see the inflammation does spill out a little bit further into the lobules of the fat, but the fat looks relatively undamaged, and it really still localizes to this side. The fat over here is uninvolved. And again, you have inflammation, relatively non-specific inflammation, but mixed with newts and eos early on, lymphs and histiocytes around this vessel wall. Okay, so that's it for vasculitis. Urticaria is in this chapter because it's sort of a perivascular and interstitial dermatitis where the inflammation comes out of the vessels and you can blanch it out and things like that. Urticaria is in the normal skin differential, and that's because we have very few lymphocytes. Why can we not see this infiltrate very much is because the lymphocytes that are black and attract our eyes are not really present here. When you zoom in closely, you can see a little bit of inflammation around the vessel and between the vessels. But when you go in closely, it's mostly just tiny neutrophils and eosinophils, which are hard to see at low power. And it makes sense because urticaria is a type 1 hypersensitivity. So IgE brings on these types of inflammatory cells, and then they come and go this way. Whereas a dermal hypersensitivity, like a bug bite or a drug eruption, you're going to see lots of lymphocytes because it's a type 4 hypersensitivity. And you need memory cells and antibodies and things like that. And so that will be much more visible by the lymphocytes. So in reference to that, dermal hypersensitivity, here we'll have a superficial and deep, and it'll be perivascular and little interstitial infiltrate with lymphocytes and eosinophils. Early on, you may have neutrophils, but they'll go away with time. And if you have a chronic hypersensitivity, you might even have a few plasma cells. It depends on the age of the lesion and how persistent it is. This is generally the category where we have bug and drug. And by bug, I mean like arthropod bites, etc., not infections. So this infiltrate is easier to see than that urticaria was, and that's simply because of all the black dots we see with the lymphocytes. And here you can see the lymphocytes and the eosinophils in a perivascular and kind of a little bit of an interstitial pattern. Another thing I think I should mention about urticaria is that you often see in the textbooks that there's edema. I would say that 99 times out of 100, I cannot really appreciate the edema in urticaria. It's really just normal looking skin where when you zoom in, you're going to see some newts and eos. And then dermal hypersensitivity, in contrast, has more lymphocytes. Okay. Neutrophilic dermatoses. So we can have really dense ones like we see in sweets and pyoderma gangrenosum, or we can have more sparse ones like we see in neutrophilic urticaria, rheumatoid, neutrophilic dermatoses, and autoinflammatory diseases. So sweets is when you have a dense collection of neutrophils, and you might have karyorrhexis. Usually you don't have much vasculitis, so damage and fibrin around the vessels, but certainly they are surrounding the vessels, and then you'll have papillary dermal edema. Sometimes rheumatoid things can be this dense, usually not. Pyoderma gangrenosum is on the differential. Often early lesions start in a follicle, and that can be a clue. And certainly you need to rule out infection or other reasons that you might have something that looks like an abscess. So here's sweets, and here you can see that you have all this faint stranding in the papillary dermis. That's from edema, so that's all fluid in there. And then in the dermis, you have a dense infiltrate. So here's your strands of, mucin and edema. And then here's your dense infiltrate of neutrophils. Here's your little dots. That's your karyorrhexis from your neutrophils. And then you have a lot of intact neutrophils as well. Here's another case, not quite as dense, but you can see neutrophils and you can see edema. And certainly you would need the other clinical features of the patient to distinguish between these entities. So here's the edema, here's your neutrophils. So what do we mean by a neutrophilic reaction pattern? This is when you have a pattern that's not quite as dense, but you have an infiltrate that's predominantly neutrophilic. So it can be perivascular and interstitial. You can have 10% of people with urticaria have this neutrophil-rich variant. So it could just be that. But you also have to think about this autoinflammatory disease category. So that's familial Mediterranean fever, Muckle wells, traps, papa, all of those. You might think about Still's disease, rheumatoid neutrophilic dermatosis. Those types of diseases go in this neutrophilic reaction pattern. So here you would look and you don't see much, right? Because neutrophils are kind of harder to see at low power. This is obviously not a zoom in of this, but over here you can start to see the little dots of your neutrophils. And here you see neutrophils, but you don't see a lot of edema, and it's not super dense with the neutrophils. And so maybe this is a neutrophilic urticaria, but I don't see any EOs, so that's a slightly more rare type. But if the patient's presenting with systemic symptoms, then you definitely need to think of those autoinflammatory conditions. Anything related to rheumatoid might have neutrophils, and then Still's, etc. All right, when our perivascular infiltrate is predominantly lymphocytic, then we have a different differential. So these have been termed lymphocytic vasculitis. I put the vasculitis in quotes because I don't actually see fibrin and vessel damage. So I really just consider these lymphocytic infiltrates that are predominantly purely lymphocytic. That means without a lot of newts, without a lot of EOs, without a lot of histiocytes, just lymphocytic. And this is sort of your differential for that. It's the differential that people talk about with the 5 L's. Not that I could ever remember what the L's stand for, but this is your list right here. So we'll go through them. So pigmented purpura, this is going to be kind of a non-specific pattern, but all it is a superficial perivascular lymphocytic infiltrate. And then you're going to see purpura, which is extravasate erythrocytes, and you're going to see hemosiderin because it usually is chronic enough to collect hemosiderin. Obviously, on day 1 of your pigmented purpura, it's not going to be that pigmented, and you're not going to see the hemosiderin. But with time, when you see these golden patches, then you're going to see the hemosiderin. You can have spongiotic or interface changes, and all of those have different names of the variants that we dermatologists have to learn, but that's not what's most important. The most important is the perivascular lymphocytic infiltrate with purpura. If you see eosinophils, then you have to think you might be looking at a purpuric drug eruption rather than pigmented purpura. And certainly a clinical presentation of, couple patches versus a diffuse eruption makes a difference. So here you see a nonspecific perivascular lymphocytic infiltrate, and that's it. You see your extravasate erythrocytes. And here you can see the little brown deposits that are your hemosiderin. If we could zoom in more, then you would see that they were clumpy and different sizes so that they were hemosiderin and not melanin. But if you ever were unsure, you could check a stain, and a Pearl's iron stain would tell you that these were hemosiderin rather than melanin, which you might stain with a Fontana-Masson stain. So perivascular lymphocytes, extravasate erythrocytes, hemosiderin. Now, if you have a superficial and deep lymphocytic infiltrate, then you might start thinking about things like collagen vascular disease, which usually has not only a perivascular pattern, but also periadnexal. So the adnexa in the skin, as a review, are your glands, your hair follicles, all of those little side items are your adnexa. So you can have perifollicular inflammation, eccrine inflammation. If you see that pattern that's superficial and deep and lymphocytic, you definitely should think about a collagen vascular disease, namely lupus or maybe dermatomyositis. You usually have increased dermal mucin, but anything inflammatory can have increased mucin in the surface of the epidermis. So we saw with sweets, we had a lot of edema up high, or any sort of spongiotic eruption, we can have dermal mucin up high. When I say dermal mucin, I mean dermal mucin down deeper in the reticular dermis, where we wouldn't expect increased dermal mucin. And then you may or may not have interface change to tip you off to a collagen vascular disease. So here we see a lot of the black dots, right? When you see these black dots, you're looking at lymphocytes. We can see a little alteration in this epidermis, and then we can see this superficial and deep infiltrate, and it's not only around the vessels, but it's also around the hair follicles. A little bit around some eccrine coils, but mostly just around the follicles. When we zoom in more closely, you can see that there's this thickening, this thick pink layer down below the DEJ. That's your thickened basement membrane. And you see the pigment drop out because you'll have a subtle vacuolar interface, meaning the lymphocytes are attacking the DEJ, and you'll have scattered necrotic keratinocytes. And then here's your lymphocytic infiltrate. Here's your perifollicular inflammation, your superficial and deep perivascular inflammation. And then if this was not such a faded slide, you might be able to appreciate that there's mucin between the collagen bundles. But if you can't see it, you could do a mucin stain. Here's another example: superficial and deep perivascular lymphocytic infiltrate. There might be, we don't have a follicle in this section, so it's hard to know if it's perifollicular, but at least we have this lymphocytic infiltrate. And what you can see in this slide that's still well preserved is that you have mucin even down to here, an even amount of mucin all the way through. So this tells me I should be very suspicious of a collagen vascular disease. And here you have an interface, you have lymphocytes, and they're causing vacuolar alteration. You might just have one necrotic cell, but it's not as prominent an interface as the other case. So the other one was discoid lupus, and you saw chronic changes, and this is more of a tumid lupus where most of the changes are in the dermis. And here's another look at that little bit of vacuolar alteration, maybe one necrotic keratinocyte, lots of mucin, lymphocytic infiltrate. So superficial and deep lymphocytic infiltrate. Other things in your 5Ls would be light. And so polymorphous light eruption is what we're talking about there. And basically, you just have that lymphocytic infiltrate. You may or may not have dermal edema. You may or may not have some eosinophils or overlying spongiosis, but predominantly you have this lymphocytic infiltrate, and it should be about the right season and the right location clinically, and then you have your answer. So in this particular case, we have a lot of massive papillary dermal edema, and it's squeezing out the top, and you see like a blister here. And then here you see your superficial and deep perivascular lymphocytic infiltrate. You see all the black dots of your lymphocytes. So here's your edema. It's pushing up through the epidermis, causing vesiculation. Here's your lymphocytic infiltrate. You have one eosinophil, so you might think, oh, well, is a drug or a bug bite on your differential, but that would be sorted out with your clinical presentation. If it's very photo distributed and it's springtime, you would think more of PMLE. And certainly if there's only one eosinophil, that would help you distinguish it more. So erythema chronicum migrans, but also any of the gyrate erythemas would be in this category of a lymphocytic infiltrate. So deep EAC, where they talk about the cuffing of the lymphocytes, which really just means a perivascular lymphocytic infiltrate. We can think of erythema chronicum migrans or any of the other gyrate erythemas. You'll have the lymphocytic infiltrate. It could be anywhere from very sparse to very dense. In erythema chronicum migrans, you may or may not have plasma cells or eosinophils, but you usually have a subtle interface for spongiosis that goes with it. So here's a case, and look, you can see you have your superficial and deep lymphocytic infiltrate. So immediately you go back to that differential. And here you have a little bit of sponge causing a little bit of scale, but not prominent. Mostly it's this lymphocytic infiltrate. And you see a plasma cell or two and you think, oh, I better check for Lyme if you're looking at an annular plaque. You might even think of something like syphilis, because I think one of the 5Ls is Louis, but those extra little clues help you go on from there. Okay. When you think of PMLE, you should think of perniosis. Perniosis is a lymphocytic infiltrate with papillary dermal edema, and it just depends on which season you're in. When I was in New York, you either were really cold or you were springtime, where people started coming out of the woodworks and going into the sun. And so you'd have very marked seasons. So depending on the season, if I saw a lymphocytic infiltrate, I would guess that I was dealing with perniosis or I was dealing with PMLE. So the findings are pretty much identical. You might favor it if it's acral. And then if there's significant interface change, you would think about a chilblain lupus. Like we said, collagen vascular disease was on the differential. So here's your acral skin, and look at your superficial and deep lymphocytic infiltrate, okay? All of these share the same patterns. You need a lot of clinical information and history, but as long as you can generate your differential, you will not miss the answer. Here again, lymphocytic infiltrate. Okay, so that just, and if this is occurring in the winter and you have, gets worse when it's cold, then you have your answer. This is perniosis. But generally, it's good for people to do, you're going to get that differential of the collagen vascular disease. You're going to be asked to check antibodies to rule out a collagen vascular disease. And so I think that's reasonable. And that is it for vasculopathy. Thanks for tuning in.